Good morning, my name is Rajwa and it's a great honor for me today to talk about ARANOTE trial with Professor Sanguedolce from Barcelona, Spain.
My pleasure to be here. Thank you for the invitation.
Thank you very much. Could you tell us more about the trial's design?
Yeah, this is a very interesting question because the trial design of this study was in a moment in which there were already two pivotal trials already published. And so the design was made in making effective the recruitment and also including areas of the world that usually are not involved in such trials. And this was beneficial for the study because we have a very diversity geographical representation of the population recruited, as well as in terms of ethnicity. The trial itself is a very straightforward design in terms of comparing patients with 18 years of age with diagnosis of prostate cancer and metastatic disease by mostly conventional imaging detected. There were a randomized 2-to-1 ratio for ADT plus darolutamide versus ADT plus placebo. And the interesting thing is that the population itself was a part of the diversity of the ethnicity and the regions of the world that were involved, spanning from Asia to Oceania, Africa, and mostly South America, apart North America and Europe, was also the type of patients. Patients that have in more than 50% actually echo performance status more than 50, when more than 50% echo 1 or 2. So including also echo 2, which was not a selection criteria for eligibility in the other two pivotal trials. So the primary outcome was a pragmatic one, the radiological progression-free survival. And as soon as were reached the 214 expected events, regardless of the arms that were these happening. And so it was a 2-to-1 ratio, 2 patients on the interventional arm respect to the one in the observational one.
Thank you very much. So what are the key results of the trial?
Well, there are multiple interesting results. First, obviously, the primary outcome was a positive result in terms of a benefit for the patients in intervention arm of 46% of lower risk of having radiological progression-free survival. But there's another aspects of the trial that need to be highlighted, which is basically the adverse events. So we know already from former trials, the ARAMIS and the ARASENS, that darolutamide is a very safe drug. And this was confirmed by this trial, confirming in terms that basically with respect to placebo, there's no difference in terms of proportional adverse events, regardless the grade, and also regardless the type of the adverse events. So, for example, including those that are more specific for the RPs itself. And this is very interesting, and this probably is due to the molecular itself, which is significantly different to the others available in the market.
So, and considering the hazard ratio, they were not so impressive. Do you know what could be the reason for it?
Well, I will be cautious and say not so impressive because actually it is impressive. But when we compare hazard ratio from different trials, we should be very cautious in interpreting them and comparing them. From the statistical point of view, it's absolutely misleading to do that. Because obviously we are referring, yes, to one potential similar outcome, but based on results of different cohort of people. And we know that exactly for the initial details that provided, that means that this was a diverse population. There were much more representation. Black American, Afro-American patients was more than 10%. Asian ethnicity representation was a third of the cases. So these first and foremost make these patients different. Different was also the proportion of patients with echo performance status, which was worse than in average respect to the other trials. And also the baseline conditions. So we need to think about these. For example, the baseline PSA was needed a triple of the median a PSA level at the baseline with respect to the other trials, without forgetting that also was higher the proportion of patients with de novo disease, the high volume disease at the baseline. So it was more than 70%, which is remarkable.
Okay. So when we, I would say, understand that the overall efficacy of all these new ARPs is quite similar, the adverse events will play a key role. How would you contrast adverse events of darolutamide to the adverse events of the other drugs that are available on the market?
So we need to think about that at the moment, or at least this was a couple of publications last year available in literature. The data from the United States and Germany reported that there was as misuse or underuse of the ARPs for the 30%, which could be accounted, for example, for the fear of the physician or even the patients to have another drug with the potential adverse events that could be added on top of the ADT. So darolutamide in this setting, in this other trial, showed there was no difference respect to the placebo group, and the reason among others is that it is, for example, a drug that doesn't cross the hematoencephalic barrier, and which makes safe, for example, for the cognitive implications, the fatigue as well, and also have very low drug-to-drug interactions. That means that also this drug interact much less than the other drugs, the other ARPs, in a setting of population that are used to undertake multiple drugs and for multiple comorbidities. So overall, this is an aspect that needs to be accounted and may actually address the issue regarding the misuse or the underuse of the ARPs in this setting of patients. So as long as the patient is on ADT, there's no reason anymore not to provide him with the addition of an ARP, in this case, darolutamide.
Thank you. So at the end, darolutamide with or without docetaxel in MHSPC?
This is a very interesting question because duplets and triplets is a hot topic nowadays. But we all know that there are patients that definitely benefit of docetaxel as a full upfront treatment line. And these are probably the patients with a very high volume disease, de novo one, with visual metastases, younger patient. And so definitely as long as these patients may be eligible for docetaxel, so there's no reason also in these cases to add darolutamide, because also in these further condition, ARASENS demonstrated the addition of the drug just provide to the patient benefits in terms of survivals and no addition of adverse events. So exactly the same thing that we said before, the addition of darolutamide on ADT alone should be the standard of care, and the same should apply for patients eligible or who would get benefit from the docetaxel. In that case, you shouldn't deny also the darolutamide.
Okay, so thank you very much for your insightful interview. It was a great pleasure to talk to you.
Thank you very much for the opportunity. Thank you.